Dr. Asokan, if we are okay, then I can briefly speak about another topic which is new in the cath lab is robotic cardiac and vascular interventions. I'm just going to be speaking, say 5-10 minutes just to give you an overview. Very soon, we have acquired our cath lab. Very soon, we would be having Corenda's robot in our cath lab. And in this meeting, following this meeting, we have a 2-day ICE course. And in the ICE course, we have simulators for robotic PCI and endovascular interventions from Corenda's. So that simulator has already landed in India, and soon we will have it in Apollo, maybe by tomorrow or day after. And also we have a dedicated session on robotic cardiac and endovascular interventions in this meeting, and we invite all of you to attend that. And it also has recorded live cases and the basics of robotic endovascular interventions. So let's talk about robotic technology. We know that robots are electromechanical machines that can be used to perform tasks in place of humans. They have probably better range of movement than the human hands, and they also have AI, which is and machine learning capabilities, where they actually not now, but in future they can actually be a good assistant or better in terms of hand movements and skills than human hands. It was used in medicine for several decades, but they were primarily used for surgery and radiation therapy, and almost all our hospitals would have robots in different parts of the surgical specialties, but their use in cardiovascular medicine began in 2000, and today they are used to do in cardiac surgery to do minimally invasive atrial septal defect closures, mitral valve repairs, coronary artery bypass grafting, and electrophysiological procedures involving radiofrequency ablation for arrhythmias. They are currently approved by US FDA for both coronary as well as vascular applications. Now, in coming to robot-assisted PCI system, this enables control of coronary guide wires, balloons, and stents during PCI from a protected, controlled, from being inside the lab to sitting outside and doing it in a very controlled fashion. How it helps is it helps to reduce the strain on the back and the radiation to the operator, but also it leads to a higher accuracy and more skillful movements and more controlled movements of the guide wire and other hardwares. Currently in practice or in the world market, we have two robotic PCI systems. One is the CorePath and other is the Corenda's, and this is the one which you are going to acquire. We already have one in our Apollo chain. And the clinical efficacy of the prototype robotic PCI system was first reported in 2006 by Bayer et al., with clinical and technical success rates of 100% and 93%. So this is the console of the robotic PCI. We are going to have a simulator day after tomorrow and for 2 days to actually do an hands-on training on this. What it does, it actually, the operator sits outside, he's without a lead apron, his strain on the back is less, and he's not in the radiation environment. And the control of the movement is excellent. And also what happens is it gives us a capability to actually, do it even from a remote. So tomorrow, maybe Dr. Samir Dani or myself or Bulan can be doing cases in far distant places as sitting in their own cities, and actually with the help of a team in other cath labs in other districts, we can actually do this procedure, and it has been done and shown to be successfully done in Corenda's system. This is the CorePath, robotic system. Here you have to understand there are two things. One, this is the cassette and the unit inside the robotic arm, where you have to manually put in the catheter or the hardware and then come out and sit and then, control the movement of the guide wire and other hardwares, be it balloon or stents from outside. There have been major studies investigating robotic interventions, both in coronary and peripheral. I'm not going to go into the details of these studies, but just for completion, we have precise Cora PCI and remote PCI studies which were done in 2013, 16, and 17, and for coronary applications. And the remote PCI was actually a registry done in 2017 with 22 patients with a technical success of 86%. And here the PCI was done with as a tele-PCI from a distance, not in that lab, but from outside. On the endovascular side also, we had two studies, RAPID and RAPID-2 studies, which actually treated 20 and 24 lesions with 100% technical success. And now this has an FDA approval both for coronary and peripheral vascular interventions. You can actually do complex angioplasties as I've shown you here. And if you are talking about the RAPID study, it is a robot-assisted peripheral interventions for peripheral arterial disease. It was a trial. It was a study to evaluate the feasibility of CorePath 200 robotic system in the management of peripheral vascular disease by PVI. And patient with symptomatic PAD due to either lifestyle-limiting claudication or critical limb ischemia affecting the femoropopliteal vessels were enrolled here. A total of 22 patients with 29 lesions were enrolled in the pilot study with a 89.7% lesion in the superficial femoral artery and 10% lesions in the popliteal artery. The technical and clinical success was 100%. And this actually led to the initiation of another study, which was the RAPID-2 trial. And this was the data of 20 patients reported this was an all-comer trial, and there were no adverse events associated with this. So these are the different robots which I'm going to skip. It is not important to know this, but what is very important is now of all the robotic systems, the Magellan robotic catheter system was the first endovascular robot, and then this was followed by CorePath and now with Corindus. We can do both, we can actually do all sort of peripheral vascular interventions, be it below knee, superficial femoral artery, aortoiliac, renals, mesenterics, carotid, or even aortic aneurysms. The EVARs are, when done with robotic assistance, actually help in reducing the contrast load, and also helps in reducing the the movement of the whole device. And also when done in thoracic setting, it sort of reduces the cerebral embolization because the contact of the hardware or the catheter is minimized, and you have a controlled contact without the device or the wire hitting the aortic arch, which has a lot of plugs. It has also been tried in carotid and neuro interventions, and this has been actually a very rewarding tool. So the benefits of robotic assisted PCI are that it reduces ionizing radiation by 95%. And we know that this is very important, especially in interventional cardiologists, where it has been shown that they have higher incidence of left-sided brain tumors, melanomas, breast cancers, cataracts, accelerated subclinical atherosclerosis. And also it reduces potential orthopedic injuries, which are as common as 10% in interventional cardiologists who have been practicing more than 10 years. And there is also improvement in the stent length selection and the device selection if you are using a robot. However, there are some limitations and reasons for slow adoption of robotic system as of now, because there is no strong clinical data comparing, or there's no randomized trial comparing the robotic and PCI or endovascular intervention with the conventional one. And it is definitely a sort of a dent on the resource, and it is a costly system, and many people and hospitals do not want to spend on this. But having said that, if you actually account for the radiation injuries to the operator and also the radiation injuries to the patients, you would actually go for this device, because the operator is probably going to do more patients, and it's not very costly. The incremental cost comes to about only $1,000 for each patient. The other limitation is that it does not support, as of now, over-the-wire coronary interventions, so it only works on a monorail system. It is not, it does not support rotational atherectomy for calcified lesion and aspiration devices. And it does not also reduce the scatter radiation for people who are there in the cath lab. So in future, the robots are also going to improve. They will have better intravascular navigation. They will have also compatibility for 0.3, 5-inch guide wire system. And they will probably also work for over-the-wire systems of hardware, and probably also for rotablation. So in future, the robots are going to be more precise and more user-friendly. And in future, what we see is a combination of robotic PCI and fusion imaging and tele-PCI and tele-endovascular intervention. This will probably be the way to go in the next decade. So I stop here, and I would be happy to take questions. Thank you very much.
Thank you, Professor Khanna, for the very informative talk on robotic cardiac and endovascular intervention. And happy to hear that you're going to start this robotic procedure soon in your place. And hope that you'll be having more trainings courses next year along with this conference.
Yeah, for sure. I mean, we really wish that we are going to show you some cases next year with robotic endovascular interventions.
Okay. And what is the limitation of robotic procedures as far as endovascular intervention is concerned?
As I told you, right now, the limitations are that it is not compatible, especially the correnders, with 0.35 systems. So many of our, endovascular hardwares, which we use in endovascular interventions, work on 0.35 hardware. So those are not compatible with robotic right now. The second thing is it also does not support rotablation. It does not support over-the-wire systems, which we many a times use. So these are the present limitations, but in future, these will be overcome, and they are working on 0.35 systems and full range of endovascular interventions.
So the procedure time will be short and the contrast also will be less.
The contrast would be less, but the procedure time eventually will be short, but there is an initial learning curve. So it's going to be taking a little longer time, but in future it will be heavily minimized.
And the radiation, of course, will be, because what we are going to face in the peripheral is the radiation. Yes. Do you think the radiation dose will come down?
That's what the trial showed, that there is a reduction of 95% reduction in the radiation dose to the operator. So it is one of the best things for an operator. It is even better than having those ceiling mounted LED curtains and all. So this is actually reducing radiation, and while reducing radiation, it also gives you a capability of very fine negotiation and of these catheters and hardwares and guide wires, especially crossing CTOs and avoiding arch atheromas while you are putting in your guide wires and large bore devices or high profile devices for aortic interventions.
Any other questions? Dr. Samir? Others? Thank you. Dr. Samir, anything?
No, just feeling very excited about Dr. Khanna. I'm not able to start my video because of unstable connection, but it's a great thing. The robotic methodology, the technology is so great, and as far as the operator is concerned, no back pains also, no practically zero radiation. Right now, one can say that for the patient, it is not extra beneficial, but in the long run, it will be, I think. And it is a very exciting advance, and it's a very exciting technology.
And for patients, Samir, I would like, in a lighter vein, I would say it will actually benefit the patients. Some of your patients or some of the patients which you want to, who want to get procedure done by you in future may not have to travel to your place. They can actually get it done at the convenience of their own city, and you can actually be able to do it. So in future, the patient would have advantage, at least in terms of getting the procedure done by a very experienced operators and accomplished operator, especially in complex lesions.
Yes, there are so many possibilities, yes.
I think you can use this modality for training for the youngsters also.
Yes,
Or you can-
actually, Asokan, you are right, and that is why for this, I mean, we had planned it as when it's a hybrid conference, so we had planned to get a simulator from Germany for robotic PCI, and now since the physical part is off, and we are having this ICE endovascular course just on 22nd and 23rd. We are actually having a simulator for robotic PCI to learn, and we are having 25 doctors from across the country, cardiologists who would come and have hands-on experience. So,
you know, for teaching, there is another technology which is surfacing, and that is the VR glasses. And with that, those glasses or the helmet type of thing, you can show what you are seeing actually in the lab and how you are operating to another operator sitting afar anywhere in the world. And he can talk to you in your ears, and he can draw a diagram on a virtual screen and explain to you how things can be done. So about teaching, you can, Dr. Khanna, talk to any fellow in Indonesia or anywhere in the world, and when he's doing the procedure, you can actually whisper in his ears what to do next. So
true,
technology
yeah.
is going to be, you know,
Science is evolving at a rapid pace, and I think with this COVID, there has been a big boost in terms of telemedicine, technology, AI, machine learning, and I think in future, and also in the way we are doing meetings and, you know, interacting and learning from each other.
Great.
So, Dr. Asokan,
Thank you, Professor Khanna, for the excellent talk. So, shall we go on to the next stop?
Yeah, Dr. Sujal Shah.